Good morning, everybody. I would like to introduce my PhD thesis, fertility-sparing treatments in gynecological cancers. And I found the button. So, my name is Ádám Vincze. I work as a resident doctor in the Department of Obstetrics and Gynecology. My supervisors and I share a vision that one day women will be able to reproduce even after the appropriate oncological treatment. We would like to achieve that through finding the best fertility-sparing options for these cancer patients. We have two specific goals in mind, the first one about cervical cancer and the second one about endometrial cancer. The first project is titled Investigating the Efficacy and Safety of Fertility-Sparing Treatments in Early-Stage Cervical Cancer, even or above 2 centimeters. A bit of background, cervical cancer is the third major cause of oncological death among women. 40% of it is diagnosed in an age frame where fertility preservation is key. Fertility-sparing surgeries like conization or different types of hysterectomies are oncologically valid alternatives to hysterectomy in those early stages where the tumor size is below 2 centimeters. The problem, where the tumor size exceeds that threshold, it becomes too large for the upfront surgical approach, and the post-treatment pregnancy rate drops dramatically. The idea is that with the help of neoadjuvant chemotherapy, we could shrink the tumor, thus a less radical surgery could become available. Our aim to find an oncologically safe and fertility-wise sufficient fertility-sparing treatment for these cancer patients. So our clinical question is about that. Which one is the best treatment for these patients? Patients who have larger tumor sizes with the intention to maintain fertility. We're investigating neoadjuvant chemotherapy followed by surgery and compare it to upfront surgery. We're interested in oncological and fertility outcomes. According to our hypothesis, the neoadjuvant chemotherapy followed by surgery provides better oncological and fertility outcomes compared to the upfront surgery. The systematic search was conducted in 3 databases. Around 12,000 hits were found in 3 databases. The search key consists of 2 domains, the first one about the disease and the second one about the treatments. After a careful selection, we found 20 eligible articles, and currently at this stage finished with the forest plots and started to write a manuscript. So the stars of the presentations, forest plot number 1, it shows the pregnancy rate. Pregnancy rate is a great outcome to assess fertility. It shows the proportion of treated women who could become pregnant. The scale ranges from 0 to 1, or in percentages 0 to 100%. 100 means that everyone after treatment could become pregnant. 0 means that no one could, just like after a hysterectomy. But both are investigated approaches, preserve childbearing potential. The question, which one is better at it? The analyzed cohorts contained approximately 1 and 200 patients from 4 and 14 observational studies. The heterogeneity was I-squared 0 and 2%. However, the confidence intervals of the I-square was quite wide, suggesting the low percentage is suggesting low heterogeneity, but because of the confidence intervals, there can be several sources of heterogeneity, like some women decided not to conceive after treatment. There were different types of neoadjuvant chemotherapy regimens and different surgical methods. So the pooled pregnancy rate of the upfront surgery was 6%. For the neoadjuvant chemotherapy containing group, it was 26%, meaning that out of 100 treated women, 6 and 26 could become pregnant. The analysis revealed a statistically significant difference, and it's clinically significant as well, between the 2 groups in regards of pregnancy rate. This highlights the potential fertility benefits of neoadjuvant chemotherapy followed by surgery approach over the upfront surgery. It seems more efficient, but is it safer as well? To answer this question, let's look the forest plot number 2. It complements the prior one, shows the recurrence rate after treatment. Recurrence rate is a crucial metric to evaluate oncological efficacy. It shows the proportion of treated women who experienced relapse, so their disease came back. Now the desired outcome is 0%, meaning that no one relapsed, and 100 means that everyone did. For the context, the same population after hysterectomy would experience below 3% recurrence rates. For the analysis, the prior articles supplemented with 2 new ones resulted in a larger population size, 150 and 200 patients. The heterogeneity was I² 0 for both cases, but the confidence intervals were wide again. The sources of heterogeneity remained the same. The pooled recurrence rate for the upfront surgery was 9%. For the neoadjuvant containing therapy, it was 12%, meaning that out of 100 successfully treated women, 9 and 12 experienced relapsed. The analysis revealed statistically no significant difference between the 2 groups in regards of recurrence rate, and suggesting that the 2 approaches have similar oncological efficacy. Given that the neoadjuvant chemotherapy approach provides better post-treatment fertility, we could recommend that for these larger tumor sizes. So our study strength lies in filling the literature gap by providing information on fertility sparing for this overlooked population. It focuses on this highly specific group without the influence of additional treatments. It has limitations like high heterogeneity, small patient number, and the fact that the articles were observational single-arm studies. Based on our currently available data, neoadjuvant chemotherapy followed by surgery may lead to higher pregnancy rates without compromising oncological safety compared to the upfront surgical approach. This has implication for practice. Women who wish to maintain fertility now are supported by evidence on fertility sparing. It challenges the conventional fertility sparing criteria, promotes personalized management that respects patient priorities. The implication for research that there's a need for prospective multicentric trials that will be able to compare them directly and strengthen the level of evidence. Let's jump to the second topic, investigating the efficacy and safety of fertility-sparing treatments in atypical hyperplasia and endometrial cancer. Endometrial cancer is the 4th most commonly diagnosed cancer with a rising incidence rate. 4% of it is diagnosed in an age frame where fertility preservation is key. Atypical hyperplasia is a premalignant condition treated in a similar manner. The first step of fertility-sparing treatment in these diseases should be hysteroscopic resection, followed by either oral progestins, hormonal IUDs, or with or without metformin. These treatments vary in their risks and benefits. For example, the hormonal IUDs contain less hormone, but there's a risk of uterus perforation during application. And we have an aim to find the best fertility-sparing treatments for these patients as well. Clinical question, which treatment is the best? The population, women with these diseases who undergone fertility-sparing hysteroscopic resection, and we're investigating oral progestins, hormonal IUDs, metformin, and their combinations. We're interested in oncological and fertility outcomes. According to our hypothesis, the combination of the 3 of them provides the best oncological and fertility outcomes. This study could highlight the differences among these treatments and help the clinicians to help the patients. In summary, we have 2 ongoing projects. The first one about cervical cancer and the population for whom currently guidelines do not advise fertility sparing, and the second one about endometrial cancer. I would like to finish with a quote from Marcus Aurelius: "Is the truth time after, and the truth never harmed anyone. What harms us is to persist in self-deceit and ignorance." Thank you.
Any questions from the floor?
Please.
Thank you. Great presentation and great person in total. So I have a question that in the first project, these articles included only one type of neoadjuvant chemotherapy or several types. And if yes, would it be a good subgroup analysis?
Thank you for your question. Yes, it caused heterogeneity because these articles, these articles used different types of chemotherapy regimens. We try to subgroup analyze this, but currently, as you can see, even with the total numbers, the patient number is not that high. So we haven't been able to do that, sadly. So there's a need for that as well. We need more prospective trials, but these patient numbers are really low. So realistically, they only so they have to be like multicentric studies. Thank you. There's a question.
Congratulations. So my only issue with this type of analysis is the prospective, and we have no information about the tumor progression during the neoadjuvant therapy. Do you have any data of this result?
You mean when patients haven't received the surgery but received the neoadjuvant chemotherapy? Yeah. We have that data. Usually patients have the neoadjuvant chemotherapy, the tumor regressed, so it's either, so if there was stable disease or progression, they got excluded.
Yeah, but altogether that is the issue, my issue, so we cannot easily compare these two oncological result because we lose this patient. So if this patient population is close to 30%, so if you have a prospective publication, in this case we have no information about the patient who has a tumor progression. And because only in RCTs they published it, because it is not an ITT population.
We have data on them, so they got back to the hospital, and if there was a progression, they got excluded. If there's stable disease or either a regression, then they could go on to the fertility-sparing treatment. On the other way, they received hysterectomy, so the radical approach, the standard approach. Okay. So we have data on that.
Okay.
Thank you for your question. There's a question there?
Thank you. It was a really wonderful presentation, Ádám. And I'm from the dentistry group, and this topic is really interesting. And I made notes, and I was wondering about the 2 centimeters. Yeah. And according to the study, how does the tumor size influence the treatments, and why is the 2 centimeters mentioned in the?
Good question. So. Currently, the guidelines, the FIGO 2018 FIGO classification, at the 2 centimeters, there's a threshold. So you can see the 1B1 and the 1B2 categories. There's the jump between the two, and currently guidelines advise hysterectomy, so not fertility sparing at all in those cases where it's above the threshold, the tumor size. So the guideline it says that only in like scientific or study protocols you can use the fertility sparing options. But of course, in real life, there are women who decided, I mean, we cannot force them to go and take the uterus out, right? So some women decided not to do hysterectomy or not to receive hysterectomy, and we have data about those patients.
Okay, thank you.
Just a practical question. After the neoadjuvant chemotherapy has no impact on the fertility. Why in this case, what do you think, how long should we wait after neoadjuvant chemotherapy before a pregnancy?
So basically these women after neoadjuvant chemotherapy, it's around 4-6 weeks, they get the surgery, and after surgery usually 6 weeks again, and then can try to conceive. So it's not about the neoadjuvant chemotherapy. Of course, neoadjuvant chemotherapy would have impact on fertility, but the other side of the thing is hysterectomy, which means 0. So we only can deal with this, yeah. So we have to wait after surgery, because neoadjuvant therapy and surgery, it's not just chemotherapy.